Good afternoon, everyone, and welcome to this week's installment of APPs in Urology Symposium. I'm very excited to welcome NP Laura Aughinbaugh from UCSD, who's going to talk to us today about pelvic organ prolapse and female pelvic floor dysfunction. Just a couple of notes for those of you who may be joining us for the first time. We are going to save questions and answers for the end. However, you can use the little button at the bottom of your Zoom screen to ask questions at any time during the presentation, and we'll just save those questions for the end. You can also use the Q&A button if you're having any difficulty with hearing us or seeing slides or anything like that. So you can just put a little comment in there and we'll go ahead and try to fix any problems. Thank you all for joining us today. And if you've been a part of this ongoing Symposium set of presentations, we really appreciate your participation. If you'd like to hear more about upcoming webinars, you can follow me on Twitter at UroPA_SD, or you can follow UCSD Urology at UCSD_Urology for all the information about the links and where to register. You can also find all of these webinars recorded and posted on our YouTube channel, and you can follow our YouTube channel if you go to YouTube and Google APP Symposium, or you will also see you'll get an email after the webinar today with the link to that as well. All right, so I will go ahead without further ado and introduce Laura. So Laura Aughinbaugh, DNP, is a certified nurse midwife and women's health nurse practitioner who cares for women with disorders associated with pelvic floor dysfunction, including non-surgical treatments for pelvic organ prolapse, urinary incontinence, fecal incontinence, and recurrent urinary tract infections. Prior to joining UCSD Health, Laura worked as an assistant professor at the University of Pittsburgh School of Nursing. She has over 16 years of nursing experience providing care to patients and their families in clinic, hospital, and community settings. Laura obtained her doctorate degree in nursing practice from Frontier Nursing University in Hyden, Kentucky, where she also earned her master's degree in nursing. She earned her bachelor's in nursing at San Diego State University. She is a member of the California Association of Nurse Practitioners, the American College of Nurse Midwives, and the Sigma Theta Tau International Honor Society of Nursing. Outside of work, Laura enjoys cooking, hiking, making donuts, travel, military veteran outreach and support, and spending time with her children. So thank you, Laura, so much for being with us today.
Thanks, Rachel. So I'm on now, right? Okay. Well, welcome everyone, and thanks for zooming in, literally, to my Symposium. I'm going to be talking about pelvic organ prolapse today, further sort of narrowed down to POP, which is easier to refer to when we're speaking. And since we all come from sort of a urology background, hopefully it'll give each and every one of you some insight on how to identify pelvic organ prolapse or POP, how to not miss it, and ultimately how to guide patients towards what they need to do to treat, or at least give them some reassurance in the process. I have no disclosures. So pelvic floor dysfunction, what we treat in the specialty that I work in, really can be defined as a group of conditions that affect all the soft tissues, muscles, ligaments, connective tissue, and whatnot of the lower pelvis, ultimately supporting the vagina, bowel, bladder, uterus, and rectum. Ultimately, as can be appreciated, very important parts of the female body that ultimately control a lot of functioning. When people have pelvic floor dysfunction, they typically end up with symptoms of pelvic organ prolapse and/or fecal and urinary incontinence. And roughly about 50% of women across the lifespan will experience these things. The specialty that we deal with this in mostly is urogynecology. As Rachel introduced me, I'm a nurse midwife and a nurse practitioner that specializes in urogynecology, which the physicians that we work with are specialized surgeons that are either OBGYNs or urologists by training that do an additional fellowship to learn reconstruction of the female pelvis. And the symptoms that we're going to deal with when people come to urogynecology specialty is obviously pelvic organ prolapse, which is our basic discussion today, but we also deal with urinary incontinence and overactive bladder, fecal incontinence when it's related to the pelvic floor, and recurrent urinary tract infection. A lot of these symptoms can not only be due to pelvic organ prolapse, but fistula issues, fistula repairs, and when women have traumas to the pelvis, major traumas that need to be fixed and have these symptoms. So our topic of excitement and interest today, we're going to be talking about POP, or pelvic organ prolapse, specifically defined as the protrusion of the vagina and or pelvic organs through the vaginal opening. What is coming out and what is seen by you and seen by the patient is just the vagina and the cervix. There's never any other organ coming out of the vagina. The vagina is like a cul-de-sac where you can't access any pelvic organs. Specifically, we're going to look at signs and symptoms and presentations so that we all know what that is, what it looks like, what the patient comes in with. Sort of timing, so in the lifespan, certain risk factors where you can believe that what they're seeing or what they're saying to you actually makes sense. Of course, important to know emergent situations. When is POP or pelvic organ prolapse ever something that's an emergency and needs to be treated like now to preserve safety? And of course, we're going to briefly, before I get to the 30-minute mark, do a little bit of management, which is obviously going to be taken care of by specialists in urogynecology, but at least you can get some guidance to your patients. So just for the normal anatomy, so we're all on the same page here, we have this nice half woman kind of picture. I'm going to use my cursor to show you. This is the back of the body, or her butt cheek. This is her front of her body. Pubic symphysis here, urinary bladder, a nice straight, physiologically normal urethra. This is the uterus, the vagina, and right behind that is the rectum and the anus. Right here is the vaginal opening, and then the soft tissues of the pelvic floor and the outside. So these pictures here are just going to kind of give a brief overview of what pelvic organ prolapse looks at. What the heck is coming out of the vaginal opening? What do you see when you do an exam and you see a patient having these issues? In the first left-hand box here is normal anatomy, where it's just like the previous one, the previous slide, where you have the bladder, the uterus, and the bowel, kind of like the butcher, the baker, and the candlestick maker. They all line up. They all work best when they're in that position. What you could also appreciate from this picture is that you can see how close they are. They are all innervated by the sacral plexus, which is the group of nerves that comes out of the lower spine here. They share tissue here, so the rectum and the back of the uterus and the back of the vagina share tissue. The back of the bladder, the front of the vagina share tissue. So you can imagine that if somebody has pelvic organ prolapse, say of the anterior vaginal wall, there's a very good chance that they have some bladder symptoms too. Likewise, if someone has prolapse of the posterior vaginal wall, they probably have some bowel symptoms. In the specialty of urogynecology, there's this unfortunate statistic called co-occurrence. So when a patient comes in with one symptom, say I have an overactive bladder, or I feel like I have something bulging out of my vagina, there's an 80% chance that they're also going to have something going on in one of the other of these three systems. And that's simply because they all share tissue and they all share the same nerve routes. Okay, so over to this little box here. This is when the front wall of the vagina starts prolapsing down. As you can see here, instead of it being nice and straight like over here, there's some laxity. The patient will have a bulge of pink skin at the opening, and you can see how the bladder is not in an anatomically correct position anymore. And this picture even goes so far as to not even appreciate a definable urethra anywhere. So you can only imagine the amount of urinary symptoms that occur when someone has sort of laxity and protrusion of the anterior vaginal wall. Another name for this would be the anterior component of the vagina is prolapsing. So in this here, we have the posterior component, or prolapsing of the posterior wall of the vagina. And as you can see, as compared to this one, the rectum is totally distorted. You have this pouching over here, unfortunately, of stool that makes bowel movements very difficult. And again, what the patient's going to have is a big bulge of skin at the opening, but this time it is the posterior vaginal wall. And in this final box over here, you can see the uterine body itself coming down, both vaginal walls just sort of collapsing underneath it. You can see that both the bladder and the bowel, neither well supported. So unfortunately, with what we call uterovaginal prolapse or uterine prolapse, you have dysfunction of all sorts of systems. So the next pictures that are going to come up are not for the faint at heart. They're a little bit graphic, so you need to prepare yourself, do now. So another name for anterior vaginal wall descent is cystocele. You can see from the picture on the left, again, you have the anterior vaginal wall failing to give adequate support to the bladder. So the bladder is kind of drooping that way, kinking off the urethra. So difficulty urinating is very, very common with this. Over here on the right-hand side, this is a actual real-life picture. As you can see, this is a Foley catheter going into the urethra. And what you just see is this large sort of bulbish ball of tissue protruding at the vaginal opening. This patient is in a lithotomy position, so this is what's going on, not even having them be vertical. This is past the opening of the vagina, so this is definitely more significant than just a little bit of a cystocele, but that's what it looks like. So a rectocele, like what we saw before, where the posterior wall is pooching down and failing to support the rectum appropriately, looks very similar, and this wasn't a mistake. I didn't put the same picture on the same wrong slide, cystocele, rectocele. The point of my story here by using the same picture is you actually have no way of telling if this is a rectocele or cystocele until you actually reduce it, follow some landmarks, do an exam, and tell if it's the front or the back wall, which I'll show shortly here with a little visual how to do that. So when both vaginal walls start to come down and the uterus follows suit, what you usually see at the opening of the vagina is the cervix. This is a picture of multiparous cervix. That's why it has a little smiley face on it. These are labia minora. This is the top of the body, the anus down here just for some anatomic landmarks. Again, this patient is laying down, so you only get a peek at the cervix, but the uterine body is actually sitting down in the vault or the vagina where it should be way up inside the pelvis. Again, you can see over here that the rectum and the bladder are not well supported, so you can imagine the symptoms that come along with that. This is when pretty much we have everything prolapsing, and everything by I mean the entire anterior vaginal wall and the entire posterior vaginal wall. In this picture you see here over on the right, those are erosions that develop on the skin of the vagina. The vagina is mucous membrane. It is like skin on the inside of your mouth. So it breaks down when it touches the inside of the thighs. It's not supposed to be rubbing against keratinized skin, so that's what it ends up looking like. This is a different picture here where it's not quite as pronounced, but we call this prostodentia or complete uterovaginal prolapse. A good thing to appreciate here, this is the bladder. You can see where my cursor is on the cartoon picture. This is really, really far down compared to where the bladder should be sitting, like over the pubic symphysis. And as a reminder, the ureters that go from the kidney to the bladder are not like big coils that can stretch miles long. So you can imagine that the ureters have quite a strain on them here. And where they implant into the bladder is going to get kinked during prostodentia. And also, you could have some kinking even up higher and end up with some really bad situations like hydroureter and hydronephrosis. So our last extraordinarily graphic picture here is after hysterectomy, a woman can have prolapse of the vagina itself. And again, I'm using the same picture to show you that you don't know exactly what you're looking at if you don't see a cervix, and really an exam needs to be done. This picture up above here where my cursor is, if no one has had the chance before to look by speculum at the top of the vagina after a hysterectomy is done. What you have left over is what we call the vaginal cuff. And the vaginal cuff, this is where the cervix used to live, comes out during vaginal prolapse after hysterectomy, or the other word we use for this is enterocele. Again, you can see the bladder and the rectum very, very poorly supported, poor functioning of those body systems, and ultimately a lot of strain on the bladder where you can have devastation to the junction of the ureters to the bladder. Okay, so with all that in mind, what's my time here? Whoop, whoop. This is how we quantify it. Is this important to somebody working out of urogynecology? Absolutely not. The importance of a POPQ really is to look at change over time, especially for research purposes. You can see crazy numbers on this little POPQ, and these are measurements with a stick in centimeters, which I'm holding up in front of the camera right now. We use these little old school pap smear sticks in my clinic where our support staff does little tallies of centimeters, and we hold these inside the vagina and to the hymen and all the other parts to measure the woman's vagina and really quantify her prolapse. But regardless of what the POPQ is, we usually do pretty much the same management because most of the management is for symptom relief, not to preserve safety. So if you're seeing someone in your urology practice who has maybe a cystocele or maybe a rectocele or even maybe a uterine prolapse, there's no expectation that you would be doing a POPQ because really it's unnecessary. So what I did want to show how you figure between an anterior or posterior wall prolapse is by taking apart a regular speculum and using the bottom blade, and by putting it into the vagina, putting pressure towards the rectum to hold the back wall and have the patient valsalva to see if it's the front wall that's moving down, and then turning it upside down and putting pressure up against the anterior wall and having the patient bear down to see if it's the posterior wall that's coming down. There's a little link on here that you can put in different measurements from a POPQ to show a patient, like on your laptop or on a screen, what their prolapse is, since it's hard for them to picture it. But really, a POPQ, if you see it, it's fantastic for research purposes, but really it's nothing that would be an expectation if you were referring someone to urogynecology for them to be evaluated. When we're looking at staging pelvic organ prolapse, as you see at the bottom of the screen here, the most important thing, if someone says they have a bulge or you can appreciate a bulge of skin at the vaginal opening, is if they are asymptomatic or symptomatic. If someone is asymptomatic and they have a vaginal bulge and their bowel and bladder function fine, there's no drama, there's nothing even to worry about. If they are symptomatic, that is the most important thing. Obviously, we want to improve their quality of life and preserve their bladder and bowel function as well. If you're interested, these are the stages of pelvic organ prolapse. You can go into a lot greater definition, you know, if you're looking at the POPQ, but really, most women will, where's my cursor? Most women will start having symptoms of, I feel something coming out, my bowel, my bladder doesn't function right, around stage 2 or 3. And definitely by stage 4, when you have a significant amount of the vaginal epithelium out of the body, will someone actually have a lot of symptoms. Okay, so symptoms. What is going to be the presentation? 2 main things. People are going to say, I feel like something is coming out of my vagina, or I feel a bulge of skin when I'm washing, when I'm straining to have a bowel movement, something of that nature. We get all types of other symptoms that come into play when patients present to us, such as pelvic pain. I have pelvic cramping, back pain, pain with intercourse, heavy periods. Really, the pelvis and all of these issues have a lot of body systems that cause these symptoms. And when we reduce prolapse, we find that a lot of people still have these same issues, and that reducing prolapse itself doesn't take away per se pelvic pain or cramping or lower back pain. Important when the patient does come in and say, I have this symptom, is to not put them in a lithotomy position and initially observe what they're trying to describe to you there, because in a lithotomy position, there's no pressure on the pelvic organs. With a Valsalva, you can sort of recreate that. But if you have them stand up and sort of stand to the side and not directly underneath them, you can get a much greater picture of what they're actually experiencing and what's coming out. So timing, when is this going to happen to a woman? 50% of women in their lifespan will have some degree of prolapse after vaginal childbirth. And this doesn't matter if it's a 4-pound baby or a 10-pound baby. Granted, the larger the baby, the likelihood is going to be a little bit higher, but really it's the process of a child passing through the pelvis, genetically how the woman is put together, and how the body heals from that. It's a pretty high statistic, and it's a shame that so many women deal with prolapse and never get the right questions asked or have the ability to report their symptoms and get treated. The two most significant times when pelvic organ prolapse is going to drastically get worse or drastically make an appearance in a short amount of time is with childbirth, of course, and then within the first 5 years of menopause, or when there's a low estrogen state. Those two passages in a woman's life are really going to make the most dramatic changes in her vagina and the support of her vaginal tissue. We use these statistics that you see here, the 5, 15, and 80. There's a 5% chance outside of childbirth and menopause that prolapse will get spontaneously better. There's a 15% chance that it will get steadily worse over the lifespan. And there's an 80% chance it'll never change. The one time that prolapse changes across the lifespan quite drastically, other than childbirth and menopause, is when people chronically Valsalva. If they have chronic constipation, chronic cough like COPD, emphysema, people who have bladder atony and who are always straining to Valsalva void, they are setting themselves up to have pelvic organ prolapse. Likewise, also people who are obese, because there's just more weight above, and it's bound and determined to push everything down, down, down. So emergent situations, very uncommon. Most of the time we're treating pelvic organ prolapse in urogynecology for people's comfort. But as you can see on these wonky x-ray pictures, are hydroureters. And this is the situation that I described when someone has significant enough prolapse that they're actually going to have hydronephrosis and kidney damage. And when these situations happen, most of the time these women present to the ER because they feel really, really cruddy and they're sick, they're vomiting, you know, I don't know what's wrong with me, I feel sick. They do lab work and creatinine is something atrocious, like 7 or something like that. And then they do some imaging and they say, oh my gosh, this person's in retention, and they put a Foley catheter in. And you can see that their uterus is hanging out. Why did this happen so suddenly? Why are these people in the ER? Is because when women go horizontal, the organs will reduce and they'll go back inside, and it will relieve the obstruction, and they'll have like a diuresis, a post-obstructive diuresis situation. These women, when they present to us, say, you know, for years I loved it because even though I had a prolapse, I never leaked urine. In fact, I never really even peed during the day. It was great. I could like get on with my life and I never was bothered by it. But then all night I flood my bed or I wake up saturating pads. And it's because these people are in retention through the day, and then they have a post-obstructive diuresis through the night. And of course the kidneys compensate and they compensate and they compensate for years until too much is too much. And they wind up in the ER with a creatinine that's atrocious. The important part of this is that putting a Foley catheter in and draining the bladder is only half of it. The other half is actually reducing the prolapse, getting the ureters to unkink so that you can actually drain the kidneys. A lot of times when this happens and we, you know, use a pessary or do what we need to do to reduce the prolapse, there's pretty good recovery, but we do occasionally have that 2-3 patients a year that end up on dialysis because they just waited too long. Okay, so in the time we have remaining, you can definitely identify prolapse. You have some idea of what you're looking at and what to do. And it's not fun ever to bring up anything to a patient that you have no idea on how to guide them of what the options are to treat. So we're going to take just a quick look at what the options are to treat prolapse, looking at the medical, surgical, and of course expected. So Actually, my forte in my practice here is being the one that fits most people for pessaries. They're fantastic devices used broadly across the world for a very long time. They're super easy to fit. They give instantaneous relief of usually a problem that drastically affects someone's functioning and comfort in their life. Most of the devices that we use are the ring, dish, and Gellhorn, which is this knobby thing down here. These other devices are not quite as often used, but they're great in certain situations and certain vaginal types. In my practice here, we have hundreds of these devices in our actual clinic. So when someone comes in for a fitting, the practitioner can feel the vagina, look at the shape and size of the prolapse, and they will walk out of here, the patient, with a pessary in their vagina. For a woman who still has a uterus, it's about 85% of the time that you can get a really good, comfortable fit. For women after a hysterectomy, it's a little bit more difficult because you change, instead of a vagina that is tighter at the opening and wider at the apex, you've now created the vaginal cuff or a surgical margin up there. So you have a vagina that has sort of divulging walls. And so the pressure on the top, it's a little bit harder to keep a pessary in there, but definitely worth a try. They are a non-latex silicone rubber. They don't have metal in them. These three up here do have metal in them, but these ones don't down here. They're fantastic. About 2/3 of women can self-manage, take them in and out themselves. For women that can't self-manage because of dexterity issues, dementia, they don't want to deal with it, whatever, they can just leave the device in the vagina and come in, and we take them out periodically every few months to make sure the vagina is tolerating the device being in there. Another non-surgical management we can do is physical therapy, which is not for the faint of heart at all. You can see this therapist over here is doing some internal work. We have not seen in large studies that, especially for women who have stage 3 or stage 4 prolapse, that doing physical therapy is going to reduce the size of the bulge. But we have seen that in some small studies in Europe that it can reduce the size for people who have stage 1 and stage 2. And likewise, we've also seen that with any stage of prolapse, it just makes the vagina feel better. Even if the prolapse isn't different, the vagina feels better just by doing physical therapy. And for what it's worth, a lot of women do that. Medications that we can use, it all boils down to estrogenizing the vagina. It's very easy to do. It gives a lot of relief to a lot of dryness, discomfort, other issues that go along with prolapse. What we typically recommend is vaginal estrogen creams, 1/2 gram twice a week, using Vagifem tablets twice a week, the estring, or prasterone suppositories. Our friends at the North American Menopause Society did a position statement back in 2017 where they looked back at the WHI study, the big breast cancer HRT study in the early 2000s, and they did this post-analysis and found that in thousands of women who were post-menopause who used the scant amount of vaginal estrogen in their vaginas, there was no long-term difference in, most significantly, cardiovascular risks or endometrial breast cancers, but in anything. So it's reassuring. We give that to our patients when we offer them estrogenation of their vagina. However, taking into consideration for patients who do have, current breast cancers or estrogen-sensitive cancers or issues with clots or whatnot, that they definitely need to follow up with their hematologist or oncologist. Okay, so surgical management, which really boils down to two main things that we do for pelvic organ prolapse. We either spare the vagina or you obliterate it. Those are the two surgical approaches. Obliteration, by I mean you're not completely sewing the vagina closed, like if you were to obliterate the urethra or something like that, but it's really creating a septum in the middle of the vagina. It's a shorter surgery, it's a shorter recovery, it's less blood loss, less anesthesia, and the failure rate of obliterating the vagina is like less than 6%. It's really the best bang for your buck, but it also keeps a woman from being able to have vaginal intercourse for the rest of her life. Fancy words that our surgeons call these are Lafort's and colpochliosis. I have a picture to show that here shortly. The other surgeries are vaginal sparing. So this does not close the vagina. They're longer surgeries, longer recoveries, more surgical risks, longer time under anesthesia. We either do it with a native tissue repair just by using the patient's own tissue and sort of cinching it up with permanent sutures, or using meshes. Our good friends at the AUA in 2018 put out this blanket statement that said, meshes are fantastic for pelvic organ prolapse repair, and they are more durable and the repair will last longer. However, more training needs to be done to people that do them, and more research needs to be done on the outcomes. So with that in mind, we're not doing a lot of meshes these days because sort of opened up a can of worms, in other words. It's the same mesh that's used when we do TVTs and TOTs. It really does work, and it gives a lot more durability to the surgical repairs as opposed to native tissue. If we can remember, native tissue is what's stretching out and having the problem in the first place. So the failure rate of native tissue repairs is about 25, sometimes 30% within 5 years. A little bit high. Okay, so quickly, because I'm now 1 minute over time. So what we do in colporrhaphies, that's a fancy word for repairing the walls, is the surgeon opens the vaginal epithelium, and with the excess tissue in the fascia, creates pleats or plication. These are just incisions that are done in the vaginal wall. This is when women have prolapse of the vaginal walls, but the uterus isn't coming down. So they really just need kind of the vaginal walls tapered up. Anterior, posterior colporrhaphies. Perinorrhaphy is actually a plication as well. It's opening the perineum. You can see the posterior vaginal wall here. Again, opening up and plicating the fascia, so to kind of pull together the tissue to help support the organs up above it. Just as a point, perinorrhaphy is definitely the most painful thing that anyone has done in our specialty. It's kind of similar to having like an episiotomy repair. Colpopexy is the term that we use for tacking the top of the vagina or the uterus to something up in the pelvis to hold it up. As you can see here in this picture, the uterosacral ligament comes from the sacrum down to the uterus. This ligament, we put a suture through and we cinch it up and sort of tack it upwards. They work pretty good. Mesh is also done colpopexy. You can see here that in this picture, this mesh is connected to the top of the uterine body and then adhered to the sacral prominence, again, to give great support to keep the vagina up. The obliterative procedure that I had referred to, which is really, really the best bang for your buck. Basically, if you are considering the vagina this sort of rectangular thing here, it's creating a septum down the middle and leaving open 2 sort of rudimentary channels there. So it's not closing the vagina completely, but it's definitely causing, lack of an open cavity. And now you have 2 sort of smaller passages. We don't do this for women who have, postmenopausal bleeding, anything wrong with their cervix, anything we would worry about that we need to be able to assess their uterus at any point in their life. And of course, there's expected management. A lot of times reassuring someone, there's only a 15% chance this is going to get drastically worse. It's not a huge tumor falling out of you. It won't pop, and it's not going to be on the floor tomorrow or next Tuesday when you wake up. Most women say, I'm fine. I just wanted to be reassured that it's not something that's going to kill me. And you shake hands and they're fine with it. So expected management is always an option. We do like to follow up with them every couple of years or sooner if their symptoms worsen. And really, as long as their bowel and their bladder function well, they don't have any renal compromise, like what we described before with the kinking of the ureters and urinary retention, things like recurrent UTIs, constipation, or whatnot. Really, we can just do expected management and move on our merry way. There's some online resources that I listed here. And that's pelvic organ prolapse in a glimpse. Any questions?
Awesome. Laura, thank you so much. That was super informative, and I love the pictures, really helpful to look at those diagrams. So everyone, if you have questions, go ahead and submit them using the Q&A button at the bottom. So So one question, Laura, you mentioned that when you have somebody, let's say, who has a pessary and doesn't want to deal with it or doesn't have the dexterity to be able to deal with it, that you might bring them back, not only to take it out, clean it, replace it, but to evaluate how well they're tolerating it. What are you looking for, and what kind of things could potentially happen or go wrong by using the pessaries?
So most of the time, nothing goes wrong at all. And the pessary sits there just perfectly fine. Granted, the device being in the vagina is going to offset that perfect balance of yeast and bacteria that live in that body cavity. And the presence of the pessary itself usually suppresses yeast levels and increases bacteria levels. So these women, if they have a dischargey kind of discomfort thing, most of the time it's a BV, a bacterial vaginosis. And we just treat periodically with like Metrogel or clindamycin cream. The other thing you're assessing the vagina for, if the pessary is a more snug fit, what can develop over time are little pressure ulcers, or what we call erosions. And they're not dangerous. They can give a little bit of funky discharge, maybe some goopy yellow or sometimes a little bit bloody discharge. And it's really kind of just like a pressure ulcer that develops from the pessary sitting in there chronically. What can help is estrogenizing the vagina, because that gives more turgor, more collagen, more tissue integrity to the very thin postmenopausal skin of the vagina for women in the later decades of life. But really, other than that, you're just really making sure that they're comfortable with any sort of those sometimes side effects that happen. And we've had some recent research come out that, you know, typically we're having women come back every 3 to 4 months that didn't remove their own pessary, but we are extending that out to about 6 months now, because we've seen that it really is no difference if people come back every 3 to 4 months or up to 6 months. The important thing is when you fit someone with a pessary is that initially you have a very short amount of time to follow up, which I never go over a week or 2 weeks at the most, simply because you're fitting this pessary in a place in the vagina where there's no nerve endings. That's why the pessary is so comfortable in the upper third of the vagina. It's like where a woman would wear a tampon or a diaphragm. And if the device is going to erode deeply into the skin, which sometimes can happen, especially with more with people who haven't fit things very for a long time, you can have some deep erosions, and of course the patient can't feel that. So I have, in my experience, had someone, you know, they're happy as a plum when they come in, oh my gosh, this has made my life so much better, and had a complete erosion from a pessary between like the rectum and the vagina. It doesn't happen often, but it can happen. So in the beginning, you want to make sure everything is status quo, and then you can extend out the interval of having them come and get their pessary checked.
One question is, someone asked, is there a simple way to clinically grade cystoceles? And so I wonder if that's referring back to the stage 0, stage 4, if you would use that same staging to stage the cystoceles.
Definitely. Stage 0 is normal anatomy. Stage 1 is that nothing is coming out past the hymen, past the little like opening, the introitus. Stage 2 is that it's coming out, but it's less than a centimeter. Stage 3 is that it's more than a centimeter. And anything stage 4 means that there's lots of tissue coming out all the time. So anything in that ballpark, like I said, if you're identifying this in your practice and you're referring to an OBGYN or to a urogynecologist, saying that it's symptomatic is the most important thing, and saying whether it's affecting their bowel and bladder function is really the most important thing. Because whether it's a stage 1 or a stage 4 prolapse, when the patient comes to a specialist, we're going to fit them with a pessary if they're willing to do that, and then discuss their surgical options. But really, whatever we can do to improve their quality of life.
If you have a scenario of a patient who comes in and is, let's say, postmenopausal female with stage 2 prolapse, and is having OAB symptoms, so is bothered specifically by urinary urgency and urgency incontinence, where do you start with that patient? What do you tackle first?
So as I stated, co-occurrence, greater than 80% of the time, they're going to come in with something of that nature. Hardly does anyone come in and say, oh, I just have prolapse. And a lot of times when people come in and say, oh, I have OAB, you're like, no, actually you have a couple other things going on too. But reestablishing normal anatomy really, really improves bladder function and bowel function more than anyone can even measure at first. So definitely with someone who has any type of incontinence, overactive bladder, nocturia, anything, I reduce their prolapse and see how they are. The last thing I want to do is introduce a bunch of interventions at once, and then they're doing all this stuff like PT, and they have a pessary, and they're taking Vesicare, and they're like, oh, my life is so much better. But now, like, they're doing all this stuff, and it's unlikely that you have to put so many interventions forward to get a good result. So definitely I fit them with a pessary, have them wear it for a couple weeks and come back, and then move forward with looking at the OAB if it's even still present.
Okay, and then last question for today. Any great Urogyne apps or pocket textbooks that you'd recommend?
So anything from the Augs and what's up on the screen here, the American Urogynecologic Society, is fantastic. There was on the PopQ slide, there was a little website, a link you could go to that is the online version of doing a PopQ. It shows how to do it. They have great little things there, and also something to show patients. So if you put their measurements into a little grid on their website, it like gives a sort of a theatrical presentation of what the prolapse looks like from a practitioner or from a side view in a patient. Augs also does a lot of advanced practice provider segments. They do every other year actually this year we did it virtual because of the whole pandemic thing, but they do conferences every other year for APPs specifically. And they're really probably the best resource to go to for anything urogynecologic at all.
Awesome. Well, Laura, thank you so much for being with us today and for sharing all of your wisdom.
You're welcome.
Everyone who was able to sign on. Laura's webinar has been recorded and is going to be posted later this evening on our YouTube channel. So go ahead if you'd like to rewatch it or to send it to all your friends. You can go and go to YouTube and search APP Symposium, or you can follow me on Twitter at EuroPA_SD or at UCSD_Urology in order to get the link to that YouTube channel later on this evening. Don't forget to continue to register for our upcoming webinars. Next week we have a fantastic webinar on bladder cancer by MD Anderson Sofia Higareda, who's going to be teaching us on that topic. And we're just really excited. We have 3 more lectures in this initial offering. If you like what you see, continue to tell your friends, send it to your colleagues, and help us continue to keep the program going. So thanks so much, everyone. Have a wonderful night.
Thanks.